Strategies. We welcome you all to this two-day e-symposium, CADRE 21, Caries Research and Diagnosis, and hope you make the best of it. Now, we would like to invoke the blessings of the Almighty by inaugural song and lighting the lamp.
I'm sorry for the technical issues. Just kindly bear with us.
I request our evergreen, enigmatic, and energetic ma'am, Dr. Mahalakshmi ma'am, the head of the department, to address the gathering.
Good morning, friends. I would again like to start our day's proceedings with a Tirukural. Noi Nadi, Noi Mudal Nadi, Adu Tanikum Vai Nadi, Vaipa Sayal. Noi Nadi is the diagnosis. Noi Mudal Nadi is the etiology. Adu Tanikum Vai Nadi is the treatment. This is the order of the day, and this was told by none other than the great poet Thiruvalluvar almost 2 decades ago, and it still holds good. So our specialty, unfortunately or fortunately, encompasses 3 disciplines of endodontics, dental materials, and conservative dentistry. Unfortunately, the importance is given in that order. And in that, cariology is not given the due importance it deserves. Now, we all know that this chronic disease is actually a pandemic, right? And we need to understand this and its ever-changing concepts. So we, the Department of Conservative Dentistry and Endodontics, SRM Dental College, Ramapuram, have organized this 2-day symposium on caries diagnosis and research. And we are happy that more than 500 delegates have registered for this conference, and with will be at by eminent international and national speakers. And for this, we also have some paper presentations, more than 100 paper presentations from students. So with this, I would like to each and every one of you all, the participants, the speakers, the moderators, the chairpersons, the delegates, the students, for this 2 days, and I hope that you will gain the maximum benefit from it. Thank you. I now request Dr. Kavita to start the proceedings, please.
Thank you, ma'am. Thank you so much. A very warm welcome to our esteemed speakers and delegates. I hope you all are keeping safe. It's a pleasure to welcome you all to the series of undoubtedly the most significant topic in dentistry, cariology. So our first speaker for our session is Dr. ABHISHEK PAROLIA from Malaysia. Welcome you. I take the pleasure to invite our moderators for today's session, Dr. Sonali Thaneja and Dr. Vidya Saraswati, for the session. Dr. Vidya Saraswati is Professor at Department of Conservative Dentistry and Associate Dean of Manipal College of Dental Sciences, Manipal. She played a crucial role in starting a short-term certificate course in dental photography at MCOTS Manipal, which is unique and first of its kind in India. Dr. Sonali Taneja is professor and head of the Department Conservative Dentistry and Endodontics, ITSCDSR Muradnagar, and Dean Student Support and Relations. She's been the past Vice President of IACD and Executive Committee member of IES. She is Associate Editor of Journal of Conservative Dentistry and Dentistry. We are very happy to have you with us, ma'am. So kindly, I request you to kindly moderate the session. Thank you.
Good morning, everyone. Good morning, Maha ma'am. Good morning, Dr. Kavita and Dr. Sonali. It's our pleasure to be a part of this program, and we both thank you, the team SRM, for this. May I proceed with introducing Dr. ABHISHEK PAROLIA?
Yes. Please.
Yeah. Maybe one of the most gratifying and memorable moments for a teacher could be the opportunity to introduce to the audience her or his student who has done so well and excelled in his career, so much that he has carved a niche for himself. Thank you, Maha ma'am, for this opportunity. And yes, I'm so glad to introduce my student, Dr. ABHISHEK PAROLIA, for the attendees today. Dr. ABHISHEK PAROLIA graduated from MCOTS Manipal and was awarded a gold medal in conservative dentistry and endodontics. Nothing surprising, he was very good then too. He has been very active in practicing endodontics and training young dentists for more than 15 years and has a vast experience in microendodontics and retreatment cases. Again, not surprisingly, his students published a video in the social media a couple of days ago, Dr. Abhishek's mantras in endodontics, showcasing his tips and tricks that makes endodontics very interesting. And currently, he is the Associate Dean of Postgraduate Continuing Education and Research, School of Dentistry at IMU, Malaysia. He has been the lead in developing the endodontic curriculum for undergraduate and postgraduate training. He received a Research Incentive Award in 2010 and that is invaluable contribution in leading ICDA's initiative in 2014, E-Learning Innovation Award in 2016. He received the Best Faculty Presentation in International Association in 2017. He's been selected as a reviewer for Cariology Research IADR 2017-2018 and nominated for the Secretary post 2018-2019 and Vice President post IADR Cariology Group. He is a member of ICDA's National Benchmark Group, Malaysia. He has secured national grants worth of total $100,000 as a principal and or co-investigator. He has published more than 70 scientific papers in national and international peer-reviewed journals and authored 5 chapters in 3 textbooks. Abhishek has conducted workshops and lectured locally and internationally at many countries, namely India, Malaysia, Philippines, Indonesia, Vietnam, Cambodia, Thailand, Dubai, Brazil. Okay, the list goes on. His key research interest areas are disinfection in endodontics, bioactive molecules, endodontic microbiology, and clinical governance. If this is a glimpse of Dr. Parolia's achievements in his professional life, as a person, Abhishek is a very balanced, down-to-earth person, bubbling with energy and radiating positivity. He has scaled so high in such a young age, however, remains grounded. This is something special about him and is worth emulating by the younger generation. Over to you, Dr. Abhishek.
Thank you, ma'am. Right, I feel emotional a bit now. All right, I will share my presentation to ensure everything goes well. Just give me a minute. Okay. Okay. Yes. Can you see my presentation there?
Yes, we can, Abhishek.
Yes, we
Yeah.
can.
So thank you, ma'am, and thank you, Malashmi, ma'am, for inviting me here. It's a privilege to be there in front of you all because, as ma'am said, I'm her student. I'm still a student. So so currently, being very fortunate to work as an associate dean in International Medical University, Kuala Lumpur, Malaysia. But before I start, I would like to thank SRM Dental College under the leadership of Dr. Mahalashmi ma'am for organizing this e-symposium on caries diagnosis and research. Can you hear me, all of you?
Yes, Abhishek,
Yes.
Right.
very clear.
So I like the introduction when it was mentioned that keep your enemies closer. And I think I would say caries is not our enemy. Caries is our friend, because caries, if there, that is why we are here. So yes, but yes, on a serious note, yes, it is our enemy, and we have been working on it to evade and to raise caries from the global setup, but still we are way behind to what we have to achieve. So show you where I work. So this is the International Medical University where I do work, and this is our preclinical and clinical setup where we do have students treating patients, and I'm training them there. And this is our clinical area. So this is my area where I do work. Most of my practice is revolving around endodontics and caryology. So we do have, I mean, when I train my students as well as participants, there is always a bit of contradiction because we are waiting for caries to go into the pulp tissue so that we can perform endo, and that makes more money. But at the same time, when I do and say prevent caries and don't let it happen and don't let it spread, so basically I am contradicting my own statement. So we need to be very careful. And I've been telling people, if you can prevent caries at an early stage, actually you can make more money out of endo. I mean, out of caries than endo. All right. So the topic which is given to me is the holistic management of dental caries based on caries risk assessment. And we know that dental caries is a very prevalent disease. It's a disease which is it's pandemic, as Dr. Mahalashmi ma'am said, and it is there all across the globe. Even in Malaysia, if you see 90% of adult population as well as more than 70% of child population, we are having dental caries. So the prevalence is really high. Now, when it comes to caries, I mean, I'm sure all of you know this personality. I mean, this is something what we have all learned about him, and he is GB Black. And believe me, Dr. Vidya ma'am is there. She will echo my voice. This used to be our Viva question. Tell me the full name of this person. You know, we don't have Viva anymore now. But actually, I feel that Viva made me a better person, because when the Viva is there, it's not only about question, it's about reading and understanding and actually explaining in front of the supervisor. So I really miss those days when we used to be scared of Vivas and used to read a lot. So the full name of this man was Green Verdiman Black. And actually, he was the one who gave the definition of cavity, not caries, the classification of cavity. And that is why my entire presentation will revolve around this. So what have been happening until now? We do all, if you call your supervisor, the supervisor comes and he or she picks up the probe. That is the first thing. We examine the patient. What do? We pick up the probe. We ask the patient to open the mouth, and then we start exploring. I remember my days. The first thing we used to say, "Amari." Amari means open your mouth, right? So please open your mouth, and we will pick up the probe and we will start exploring. And the second thing, what we want to do is we want to drill and fill and build. So the entire focus used to be just identify any discoloration and drill it and fill it. But I think we need to go a way more in that. The drilling and filling is not the key concept anymore. We have to really identify or determine the factors involved. We have to detect the lesion and diagnose rather. We have to decide, and that deciding part is really important, which we actually overlook. And thereafter we go for performance, means the drilling of the cavity if needed, we call it do. So when I say the 2D to 4D, that has made a lot of difference in our journey, because the way I used to treat dental caries 10 years back and the way I treat dental caries now, there is a huge difference. And I'm going to share my experience with all of you. So there is a paradigm shift. And earlier what we have learned, and I'm sure you guys are learning even now, the amalgam cavities, the class 1 to class 6. If we are not defining the cavities anymore, we are defining dental caries, and we don't want cavitation to occur. So we want to identify dental caries before cavitation, and that's how our focus should be. The focus should not be, oh, there is a cavity, let's fill it up. No, the focus should be, there is a possibility of developing a cavity, and how can I prevent it before cavitation? So that's how this entire ICDAS, which is International Caries Detection and Assessment System, has been evolving. So the journey started in 2002 when the international cariologists and experts came together, and they were working on different assessment methods. How can we make the management of caries better, and in using a more preventive strategies? And thereafter, the ICDAS and ICCMS came into the picture. Now, I was very fortunate to be trained by Professor Kim Strand and Professor David Ricketts from Copenhagen and Dundee, who actually changed my entire perception about dental caries. So now, what is ICDAS is basically caries to the starting from core to core. Now, I will take you to a basic structure of ICDAS, and thereafter I will talk about how do we actually assess caries, diagnose caries, what is the importance of risk assessment tools, and ultimately how do we manage dental caries. BDS more than 22 years back, and during that time, the understanding of dental caries was a bit different than what we have now. So now we understand the pathophysiology better, and that is why we can actually go for more preventive strategies than interceptive strategies. Now, as I mentioned, this particular system started in more of Europe, but in Asian, we were the first one who actually in this. Now, again, it is not the classification of a cavity, it is a classification of dental caries. And that is why those who are pro, I thought in my so it's more visual examination. Now, when I say examination first, what we so that is something very important for us to understand. It's a visual examination process first. We will use it we will use the probes whenever necessary, and I will tell you where all you can use the probe. Now, coming to, there is a e-learning video, which I'm not playing here, but there is a 90 minutes video. Those who are interested in learning more in ICDAS, there's a beautiful video of how to detect or identify dental caries using ICDAS. So you can go through it in site. So to just give you a brief idea about coding, how do we code under ICDAS? And I know some of you may think that it's too difficult for us to identify. Actually, it is not. We consider dental caries or discoloration caries in ICDAS. So any discoloration which is not due to dental caries, we do not consider under ICDAS, number one. Number two, we also do not consider any abrasion or any non-carious lesions. For example, abrasion, effraction, attrition, or erosions. Those are not considered under ICDAS at all. Now, when I show you these two pictures of coding 1 and coding 2, which when I say the coding 1 is when the discoloration is confined to the pit and fissures and can be seen only after saliva, after removal of saliva or moisture. And if you can see the spread of those lesions beyond the fissures and can be seen in the presence of saliva, immediately I know some of you are thinking, oh, I will go for this kind of a treatment. The moment we see this, our management starts in our mind. Oh, this one I should go for fissure sealant, this one I should go for PRR, or this one shall I go for amalgam or composite resin restoration. I really want to inform you all that we should stop thinking in that direction. Right now, I'm only at the identifying stage where I am just saying whether it is code 0, code 1, or code 2. My management is not going to be dependent on what I see. The management is going to be dependent on many more factors, which I will talk about in a while. So code 1 and code 2, some of you may think, oh, I'm not sure whether it's code 1 or code 2. In that case, you can go for the lower scores. Instead of code 2, you can always score code 1. That is not a problem. But
restoration composite coupling of high. Okay. And also she has a class 1 section.
May I request others to mute themselves?
I'm attending a conference, so you call me, I'll come.
Dr. Kavita?
yes, even I'm attending the conference. All right. So the code 3 is the initial cavitation in enamel. So imagine the cavitation starts at code 3. It does not start at code 1, but dental caries, it has already started at code 1. So if we can identify this part, that before cavitation, if we can identify dental caries, believe it or not, you will not have so many cavitations what you encounter in patients. Now, code 4 is when you see a hue or a bluish or darkish hue, that means my caries have gone into the dentine. It may have a superficial enamel, it may not have superficial enamel. So in code 4, definitely we may have to prepare the cavity and we may have to restore the cavity. But in that case, I will also talk about how to preserve the tooth structure as much as possible when we are preparing the cavity for these kind of cavitation. Now, code 5 and code 6, when there is a frank cavitation involving the dentines. So some of you may get confused between code 3 and code 5. Now, code 3 is the initial enamel cavitation where there is no exposure of dentine at all. While in code 5 is the frank cavitation where there is an exposure of dentine less than half of the tooth structure. While 6 goes when it is involving half or more than half, both width-wise as well as depth-wise. Now, I know it's difficult to remember all these codes. So that is why I will talk about the clubbing of coding, where we can club code 1 and code 2 together and code 5 and code 6 together. However, code 3 and code 4 remain separate. So what I mean to say, whether you said code 1 or code 2 is same, code 5 or code 6, interchangeably, it remains okay. But 3 and 4, we cannot merge. But again, I'm saying that management does not depend only on the coding. We will talk about the management. Now, when I say the code 5 and code 6, that means we have to have a transitional line angle. So when I say half or less than half of the surface, that means within the transitional line angle is one surface. Right. So these are some of the clinical pictures you can see starting from code 0 to code 6, which will actually help you to identify how do we actually detect carious lesions based on the coding. Now, if I show you the extracted teeth, even on the smooth surface, we can see this. For example, the one which you see here is code 2, which can be seen even in the presence of moisture. But it's quite easy to see after extraction. How about in the patient's mouth when you have an adjacent tooth nearby? So you may need dental flossing, you may need transillumination, you may need to go for bite-wing radiographs. So just to summarize, if you are confused between a higher code or a lower code, you please go for the lower code. But if the one code, for example, if the occlusal surface is involved, and that is having code 5 and extending to the buccal aspect, which is a tiny cavitation code 3. In that case, I will just confirm that, okay, my code 5 is the severe one. So I will go for the severe code. So I mean to say, when you're confused between code 1 and code 2, you go for the lower code. But when you are sure that there is a code there, which is a severe one, And it is extending to the different surface with a smaller chord, then you have to code the severe chord. Right. In the proximal lesions, you may have to use the transillumination, because transillumination will actually help you to identify the carious lesion in the proximal area clinically. Now, let me take you through a coding system of the radiographically, but before that, I would like to say, please stop using sharp probe. I know we have been using curved explorer or right angle probes, which are really sharp. I think we should, even though if you want to identify the depth of the cavity, and if you want to differentiate between port 3 and port 5, I think we should go for a blunt end probe, or WHO probe, or CPTI probe instead of using sharp probe. Now, this is the overall picture. How do we actually start assessing and detecting the carious lesion starting from code 0 to code 6? Actually, it was shared by Professor Kim Strand, who actually trained me for ICDAS and ICMS. Right. Coming to the merging of coding. Now, when you look at the merging of coding, you can always merge the codes for the better and easy identification. Because I know, when I've been training here to students and the dentists, to be honest, it is very easy for me to train students because they are fresh. So they are learning something new. But when I train the senior people, it's so difficult to train them because they have a very fixed ideas and they don't want to change. I am not saying my teachers are like that. My teachers have been very, very flexible. But what I'm trying to tell you here, that I don't want to call them, I always call them experienced people. Those who are very experienced people, they are very difficult to train. But once you train them well, they become your ambassador and who can actually spread the news and spread the training so fast. So they used to find it very difficult to code 0 to 6. How do I remember everything? So even if you don't remember, you merge 1 and 2 together, 5 and 6 together, but 3 and 4 remain separate, as I mentioned before. Now, again, I'm mentioning these codings which I am showing you here is just the initial step where you are asking the patient to open the mouth and you are observing. But before that, there are a lot more things which you have to ask and gather the information from the patient, which I will talk about. So imagine if you're taking the radiograph and you want to see the lesion into the enamel and dentine and how to remember this. So let me show you in a schematic diagram here. So enamel thickness is lesser, dentine thickness is a bit higher. So what do? We divide enamel into 2 halves and enamel and dentine into 3 parts. So the lesion which is involving the outer half of enamel, which you are looking into the radiograph, if you realize that it is involving the outer half of enamel, I will call it RA1. R stands for radiograph, A for initial lesions, B for moderate lesions, and C for advanced or extensive lesions. While if it involves the inner half of enamel, it will be called as RA2. And if it is involving the outer 1/3 of dentine, it is called as RA3. So you see there are 3 initial lesions, which is RA1, RA2, and RA3. And if you remember the clinical setup, we also had code 1, 2, and 3, which are all initial lesions. Now, the moment it goes in the middle 1/3 of dentine, it becomes RB4. That means if someone tells me my patient's tooth is having RB4 lesion on the mesial surface, I immediately know that the patient is having a caries which is involving the middle 1/3 of dentine. I don't need to say into dentine, deep into dentine, superficial in dentine. I just need to say RB4, and I know my caries have got into the middle 1/3 of the dentine. Now, when it goes in the inner 1/3 of the dentine, it becomes RC5. And when it involves the pulp tissue, it becomes RC6. So C lesions are advanced or extensive lesions. So if I show you all RA1, 2, 3, RB4, RC5, and 6, you can easily identify the lesions in the radiograph, what we can see. So now I will tell you how did it help me and my students and my other colleagues. Earlier, when we used to look into the radiograph, we used to just look at that and say, oh, there is dental caries there. Now what do? We assess and we really look into the radiograph for a little longer time. because we want to assess whether the caries is in the enamel or caries is in the dentine. If it is in the dentine, where exactly it is in the dentine. So that has helped me to correlate this with my clinical findings, and that really helps you during your treatment strategies as well. So now I mentioned about the coding in the clinical setup. I have mentioned about the coding into your radiographical setup, and then I would like to show you caries in the which are associated with the restoration was so-called secondary caries, which we talk about. So these are some examples of radiographic pictures you can see starting from RA1 to RC6. Now, when I talk about caries which are associated with the restoration, so we don't call it secondary caries here. We say caries which are associated with the restoration. So this becomes 2-digit coding. So the second digit coding remains the same, what I mentioned to the clinical setup one. The first digit will tell you what type of restoration it is associated with. So for example, if I'm having an amalgam restoration, that means there is, I will code 4. If I'm having tooth color restoration, for example, composite resin or GIC, glass ionomer, I will code it 3. But the second digit will remain the same, which is code 1 to code 6, which I have already mentioned to you. So just to give you an example, now if you see, for example, this is my amalgam restoration and this is my code 1. So this is going to be 4-1. So 4 stands for amalgam and 1 stands for caries. However, if it is the same caries which is associated with the restoration, which is tooth color, it becomes 3-1 because 3 stands for the type of restoration. For example, you see here, if I say it is a cavitation, initial enamel cavitation, it's code 3. So this becomes 4-3 and this becomes 3-3. So similarly here, it becomes 4-6 and 3-6. So this is about caries which are associated with the restorations. Now, finally, we have root caries. So root caries is very simple. We have 0 means no caries, 1 means when there is a discoloration but there is no cavitation, and 2 means when there is a cavitation. So you can see here on the left hand side, you see there is a discoloration but there is no cavitation. However, on the right hand side of the picture, you see the cavitation. Whether it's deep cavity or a shallow cavity, we give scoring 2 for the root caries. However, for the coronal part, which is the crown structure, we will follow from code 1 to code 6. So overall, I gave you an idea of coding from clinical setup, from radiographical setup, from your caries which are associated with the restoration and the root caries. And what are the advantages of using ICDAS? One of the advantages is easy communication. So someone tells me this is the caries in relation to this aspect, I understand. So I can use it in the clinical setup, I can use in the research, and even in the field survey, you can use it very well. As I mentioned, so you can really it can help you to carry out certain research projects, which I will share with you in a while. Now, it has been quite, there is a data where you can say it is quite valid, and it is quite, you can reproduce the results whenever you use it. So I say the responsiveness, the validity, the reliability is quite high when you're using the ICDAS system, which you can see even in the paper, where is a systematic review published recently. And you can see ICDAS has also been compared with the commonly used diagnostic caries diagnostic tools such as Diagnodent or SoproLife or Caries Scanner. So it has also found to be quite effective when you are compared with the one which we have been using day in and day out. Right. So there are multiple papers on that, which I would like to inform you to read about them, because you can actually see that ICDAS has been quite valid to use, and you can really use it in your clinical practice. We have been using it for last 7 to 8 years now. Right. So certain key points to remember about ICDAS, as I mentioned, it is a caries classification. It is not a cavity classification, number 1. Number 2, please stop using the sharp probe. When you are using the air dry to remove the saliva, you should not air dry for a longer time. Transillumination is going to be a nice tool for the proximal caries. In case of doubt, always go for the lower score. But when the one code is extending to the to the other surface, then you have to go for the severe code. Transitional line angle will determine the surface And then you have to ensure when there is a permanent tooth and the primary tooth in the same position, then you just need to score the permanent one. You don't need to score the primary at all. Now, there are a few more things which I would like to mention. That probing, you use the blunt end probe. Please do not use sharp probe, because sharp probe, sometimes it may damage the tooth structure. It depends on the amount of force you are applying on the tooth structure. So try to avoid if you can. Now, coming to the most interesting part of the lecture, that is the management strategy, and this is we use ICCMS. And ICCMS is the International Caries Classification and Management System, and there is a proper site for it. And I would recommend all of you, those who have not gone through this site, please go through this site. And they mention 4D. And if you, and actually this is very surprising, because when I started learning about this, I used to think I'm doing everything what they are telling me. But actually we are doing it, but we are not compiling all the information what we have. And that is why we are not able to translate that information into our management strategy. What do? We actually follow 2Ds. We really follow 2Ds, which is detection and doing. And what we miss, what we gather the information, but what we miss to include the information is the first D and the third D, which is determining and deciding. So these 2Ds, we gather the information, but we do not translate that information into our management strategies. And that is why I would like to focus on that part. So it is there. There is an educator guide for everyone. If you read that guide, you will have a very clear explanation about the management strategy. So it is there. Even it is there and this is the practitioner guide and educators. If you want to read, you can read. So Nigel Pitt is one of them, and Nigel Pitts and Prof. Kim Strand and David Ricketts, 3 people. I have been very fortunate to meet them and actually have an interaction with them. So it is there in the iPad. You can use it in the iPhone, and you can actually use it in the field areas, and you can carry out the research using this. It is a very, very simple tool which can be used in your day-to-day practice. Right. So coming to ICCMS, there are a couple of papers which I have read, and I realized that how have they actually, when I was doing the training and when I was reading and trying to implement into our system, that actually helped us to implement, because you can correlate your ICDAS and ICCMS together. And why am I correlating ICCMS? And this is very interesting, because there are certain advantages of using ICCMS. The advantages of ICCMS is that it is actually linked with ICDAS. It is assessing the caries based on the risk assessment model. It is also assessing the caries activity. It is not only identify the caries lesion, which I discussed with you about coding. It is also assessing the caries activity. And thereafter, the most important thing which I really liked about this system is it is not only for interception, it is also for prevention and follow-up. They really pay a lot of attention on the follow-up, because when you do the follow-up, you will understand if the patient comes to me having the high caries risk, and after assessing the patient overall condition, I say you are a high risk, high caries risk patient. My entire strategy should be how to reduce that risk from high to moderate and moderate to low. So if I'm focusing on that strategy, if I'm not doing the follow-up, how do I know whether the patient has gone down to a low caries risk? So that is something which this particular system can help you. Now, when I saw this picture, I was like, oh my gosh, how to do it? It is so difficult for me to absorb. So now I would like to give you a trick, what my teachers taught me. Whenever you see something very hard, break it down. Break it down to small things. And then it's going to be easy for you to understand and remember. And that's how I did. So what did I do? I actually split into 4 areas. What if first is determining. Now, when your patient comes to you, what do? We read the patient, we ask the patient, why have you come here for? And the patient says, for example, pain or anything. What do? We ask the patient about their history. We take the medical history of the patient. We take the dental history of the patient. We ask the patient, how many times do you brush? What type of toothpaste do you use? We actually ask the patient about their diet, social history. So we are gathering all this information. And I'm sure all the graduates and postgraduates, those who are listening to me, you will relate to me that all of you are doing this day in and day out. That is our first thing what we do. But when you are doing this, record this, because when you record this, this is going to be an important aspect. I always say it's an asset for us. Then this information is an asset for us because this is going to play an important role in your Caries risk assessment. Now, the second part, what we do, we ask the patient to open their mouth. When we ask the patient to open their mouth and we say, okay, we find a lot of plot retentive areas. We find, suppose, as I mentioned to you in the previous one, suppose the patient says, I have gone through a cancer therapy. I will straight away put the patient under high caries risk. If I see a dental sepsis in the patient's mouth, I straight away put the patient for the high caries risk. But I'm also trying to gather the information if the patient has got previous restoration, whether that restoration is polished or plot retentive area, or a denture, or a brackets or braces, or if the patient is having root caries with a lot of plaque, gingival recession. So you have to really look into the patient's mouth, not only in the coding part, that is your number 2. The first part is you are gathering the information from the patient history. The second part is when you are examining the patient, you are actually looking into all the areas where patient is having plot retentive areas and the sepsis, or any other areas which will lead to plaque accumulation in the form of brackets, braces, irregular restorations, overhang restorations. So you need to look into it. You also need to look for child patient, you need to see whether patient has got a habit of nursing bottle. So you may have nursing bottle caries and all those things. So you gather this information together. Then you detect. So detection is what I just showed you in the beginning. Where is ICDA? So we are detect. So that is number 2. That is part. Second part, what we say. Okay, so we say this particular patient, we have gathered the information from the patient, which is our history part. Second part is we have gathered the information by looking into the patient's oral cavity. The third part is, which is the detection part, is we are gathering the information of the Caries lesion. So Caries lesion, the information is basically we are having 2 information. One is what type of code patient the Caries lesion is having. Number 2, what is an activity of the lesion. So whether it's an inactive lesion or an active lesion. So when you identify the lesion, you do not just identify the code, you also identify the activity of the lesion, because that will help you to decide, as I mentioned, to decide if the risk assessment part. So what do? We see the signs of active lesions or inactive lesions. For example, when we say it is a soft Caries lesion or a hard or firm Caries lesion, it is yellowish or dark brownish, or it is easy to scoop out, or it's difficult to scoop out. If a patient, I mean, you need to talk about the activity of Caries lesions. So for example, activity of Caries lesion can also be assessed by looking at the bleeding on probing, or sometimes you can see the inflamed gingiva. That means if my tooth structure, for example, this is code 2, if I'm having the inflammation here, that means that it is a plot retentive area. So though the plot retentive area, what I see here is a code 2, a code 2 with the active Caries lesion will have a different strategy than the code 2 of an inactive Caries lesion. So as I am repeating again, after gathering the information from the patient history by asking the patient about their all this medical, dental, social, oral hygiene habits, type of toothpaste and everything, looking into the intraoral factors, which are the plot retentive areas, then you are also looking into the coding as well as the activity of Caries lesion. For example, when I show you this and when I show you this, there is a difference. You can see these lesions, what you see on the top is active Caries lesions, while when you see on the lower pictures, these are inactive Caries lesions, but they are deep lesions. So different codings can be different ones. So we will talk about the management later. I'm still not thinking about my doing part. I'm still at the detection of part. So I finish my determination. I'm doing my detection, and thereafter I will decide. So we can club the clinical pictures, means the information what we have gathered from the clinical side, as well as if we are asking for the radiographs. So we can club these 2 information, and that can actually help us to have a better deciding factor. So we have done the determination part, we have done the detection part, and then we will combine all this information And once we have combined all this information, what you can see in this picture, then we will go for the third part, which is deciding part. And this is something which I really believe in, because all of us, what are we doing? We are actually identifying dental caries and straight away informing the patient that you need a composite resin or amalgam, and we start explanation about the advantages and disadvantages of different types of restorations. Risk assessment tools are many, and which one shall we go for? I leave it to you. But in IMU, where I'm working, we have developed a tool based on ICMS. There are different tools starting from which is from North Carolina, or even from NUS. People have come up with their tool. Canberra is one of them. Traffic light system. There are various different types of risk assessment tool. I leave it to you which one you want to use. Any tool which you have been using, which is giving you right results, you should use it. But you should use the Caries risk assessment tool. Now, when I was talking about the risk assessment tool, I have always been questioned. So which tool you use? And I will talk about which one I use in a while. So I was going through a literature, and a lot of papers you can see here. I was going through where there are a lot of systematic reviews done on risk assessment tool for early childhood caries, done on the quality of studies which have been taken into consideration to assess the risk assessment tool. There was a beautiful paper published. Are we having Caries risk assessment tool which are standardized and effective? And this is a very interesting paper when I read this paper published in 2018. So there are various types of papers published on risk assessment tools. And I can show you, even now we are having a lot of evidence on talking about different tools and different results. And sometimes you realize that there is no outcome. So when I was looking into all these tools, and this is the picture which shows all these tools of different parameters, what they have come into, I could after looking into all the data, there are three things which we all need to look into. One is the validity, reliability, and responsiveness. Means how reliable my tool is. Reliability means if I change the conditions, my tool should be able to decide the right aspect of it. So that is called reliability. Means it will produce the same results under different circumstances. How valid my tool is means whether the Caries risk assessment tool, if I'm measuring something, if it measuring that thing only. So is it measuring the parameter which it's claiming to measure. And third thing is the responsiveness. The responsiveness means if I'm going to carry out certain preventive or treatment strategies, will it be able to capture the outcome of that strategy? Means if the patient was a high caries risk earlier, based on the assessment tool which I have used, and I have taken certain preventive strategies now, am I able to capture the information that yes, my preventive strategies are working, and patient who was a high caries risk earlier is becoming moderate or low caries risk now. So these things should be there. So overall picture, if I see, there is no one tool which can be declared that this is the best tool you can use. There are multiple tools with multiple pros and cons. So the one which we use in IMU, so what we do, we follow the ICMS pattern. Even ICMS, if you read, they recommend to use any tool, including camera or traffic light system which you are using. But I would like to mention that we have to use the Caries risk assessment tool at the third D, which is called deciding factor. So what do I do? So we have this in the form. So in each and every computer here, because we have the paperless system. So what do? We gather the information and we keep on adding the information here. I cannot show you here as such, but I don't know whether if I start showing you my this one may get disconnected. So what do we do? I will just tell you here. So what do we do? So we ask the patient about the information. So when we are gathering the information, for example, if I say patient is gone through a radiation therapy because of the cancer, or patient is on hyposaliva, for example, a patient is on drugs which is leading to hyposalivation. So I will put one here. One means it is present, and once I put one here, automatically it will become red here. But only for this. But if I'm gathering other information, Depending on the number of information I'm having here, it will convert into red, yellow, or green. Similarly, when I will examine the patient's oral cavity, I will gather the information. So once I have gathered both information, what do? I go and this will tell me whether it is high, medium, or low. And then in front of high, medium, and low, I will put my scoring based on this, whether I am having initial lesions or a moderate or advanced lesion, or if it is a moderate or advanced or initial lesions, it is active lesion or inactive lesion. So once I have this information, this automatically becomes yellow, green, or red. So this is something which I'm using in my clinical practice, which really helps us to identify whether the patient belongs to high Caries rift or low or moderate Caries rift. So just to give you an idea, what do? We gather the information from the patient. We gather the information of the lesion. As I say, lesion information gathering is not only whether it's an initial lesion or moderate lesion or advanced lesion, also what type of activity the lesion is having. And then we gather this information and then we say whether this patient belongs to low likelihood, moderately likelihood, or high likelihood of developing new carious lesion. Because my idea is not to stop the lesion. Just to manage those dental caries which I see. My idea is to manage my dental patient, not dental caries. My manage patient in such a way that he or she should not develop new dental caries. So that is something very important, that we need to look into a patient holistically instead of looking into the dental caries itself. So now finally we come to do part. So imagine we have detected or diagnosed rather, then we have decided that what are we going to do, and then we do. So in the do part also, we have 3 strategies. One is preventive strategy. Second one is non-operative care strategy. And third one is called tooth preserving operative care strategy, TPOC. Now, how we go about this? So if there is an initial lesion which is inactive, means, for example, if code 1 and code 2, which is inactive carious lesion, I will go for preventive strategies rather than drilling and filling. If it is whether it is a low likelihood, moderate likelihood, or high likelihood, it doesn't matter. I will go for a preventive strategy. But if it is an active carious lesion, the same initial caries, for example, if I realize there is a pit and fissure on the occlusal surfaces, which are very initial code 2 lesions, but I see a plaque accumulation on top of it. That means that those carious lesions are active and there is a high likelihood of developing caries there. In that case, I can go for non-operative care. That could be a fissure sealant. Instead of trimming it, drilling it, I may just clean the fissure area. I may put an etchant and I may put a fissure sealant there. But when it is a moderate likelihood of developing a moderate lesion or extensive lesions, in that case, we have to decide whether we have to go for non-operative care or operative care. When we are going for the operative care, we have to go for tooth preserving operative care. I know for amalgam, if you're going for amalgam, we have to follow the guidelines of amalgam cavity preparation, which we call principles of cavity preparation for amalgam cavity. We have to create that. But when we are going for the tooth color restorations, which we are more into adhesive dentistry now, then we have to preserve the tooth structure as much as possible. So just to come to the preventive strategies, as you know, in the low setup, when the patient is low caries rift patient, in that case, I will just go for fluoride varnish twice in a year. Even for medium one, I will go for fluoride varnish twice in a year, but we may have to go for some other strategies like fissure sealants and others. But for high caries rift, the fluoride varnish application could be 3 to 4 times in a year, and we have to go for a lot more strategies than just by fluoride application. So how do we go about this? How do we actually assess the preventive strategy? So let me talk more about, because we all know interception or drilling strategies where we are preparing the cavity and restoring it well. But we have to focus more on the preventive strategies, and that is why what do we do? So
this is Nick. He's 17 this year. Let's say Nick came into the dental clinic for a check.
Can you hear the sound?
Yes, we can.
Right. So I am just going to do a video where it will give you an idea when the patient comes to you, how do we go about this? Yes.
This is Nick. He's 17 this year. Let's say Nick came into the dental clinic for a checkup with a primary concern of having multiple black spots on his teeth. To establish his caries risk, a few questions were asked. Do you have any medical conditions or are you taking any medications? This is to know if he has a history of head and neck radiation, indicators of dry mouth. What sort of toothpaste do you use and how often do you brush? This is to know his exposure to fluoride and his oral hygiene practices. Are you currently working? For his socioeconomic status. Do you snack or drink any sugary drinks? Next, we look at the inside of his mouth to look for any risk factors like dental sepsis, caries experience and active lesions, evidence of sticky biofilm in plaque stagnation areas, deep pits and fissures, exposed root surfaces. We also seen that he has ICMS code 2 lesions on all his 8 molars.
So you see, I'm putting all this information. You can see the change happening in this area. You see it in yellow. You put all the information. So it's a moderate likelihood of developing new caries disease.
Based on the patient's findings, intraoral findings, ICMS codings and caries activity, Nick has moderate likelihood of developing caries. Since he has active initial lesions, we will implement a personalized caries prevention plan and provide a non-operative care of lesions catered to patients with moderate risks such as diet counseling, oral health education like brushing twice daily with fluoridated toothpaste, prescribing fluoride mouth rinse, applying fissure sealants, fluoride varnish twice a year, and recall every 3 months.
Right, so this is the overall picture which I have shown you. So now I will take you my last 10 minutes of presentation where how do we actually go about the preventive strategies, and that is something which we follow NHS guidelines where when I show you number one, that means this is the most valid and evidence-based practice what we have been following it here. So when you look at this, wherever you see the evidence number one, that Roman 1, that means that is the evidence which is the best so far what we have been practicing. Now, when you say the preventive strategies for caries in children from 0 to 6, the first thing what we need to understand, the moment the tooth erupts, we have to brush their teeth. And how much should be the fluoride content? It has to be fluoridated for sure, and it should be around 1000 ppm. Now, anything less than 1000 ppm is not recommended as such. Now, when it comes to low caries risk patients, in that case, if the child has grown, in that case, we can go for 1000 ppm fluoride toothpaste, and professionally, we can apply fluoride varnish twice in a year. But if the patient is high caries risk, in that case, we may have to go for, it is still 6 years, we can go for fluoride toothpaste, which is having 1350 ppm. And we may have to go for fluoride varnish application more than twice in a year. And we have to look into the diet history of the patient. And we may have to use the Eat Well guide for him, diet counseling, oral health education. But if the patient is from 7 years plus, young adults, in that case, if the patient is low caries risk, I will go for a fluoridated toothpaste, which is 1350 ppm, and apply fluoride varnish twice in a year. But if the patient goes for a high caries risk, in that case, the fluoride application will go from 2 to 4 times in a year, 3 to 4 times in a year for sure. We may have to prescribe a fluoride mouthwash. That's why you will see all orthodontists, when patients they realize that patient must be having moderate to high caries risk, they give you a fluoridated mouthwash. You may have to go for oral health education as well as the Eat Well guide and all those things what you see on the right hand side. But when the patient is an adult patient, in that case, if the low caries risk, you just ask the patient to continue what he or she is doing. There is no need to apply any fluoride varnish, but the fluoridated toothpaste should have a high content of fluoride compared to the one which is 1000 ppm. But when it goes to the high caries risk, again, we will add up with the fluoride mouthwash, with the diet counseling, with the Eat Well guide, the oral health education, and the fluoride varnish application is going to be 3 to 4 times in a year, including fissure sealant whenever necessary. So this is the entire picture of the oral health toolkit, which is a third edition where NHS follows, and we are also following in our clinical practice. Now, coming to the fluoride varnish should have 22,600 ppm. I'm sure all of you must be familiar with different kinds of fluoride varnishes. Nowadays, especially in the University of Hong Kong, they really work on fluoride, a lot more on sodium fluoride, calcium fluoride, strontium fluoride. So we should have 22,600 ppm minimum fluoride varnish application. Now, so to summarize this management preventive strategy, as soon as the tooth erupts in the oral cavity, we have to use fluoride toothpaste, which is 1,000 ppm. We have to ensure that fluoridated toothpaste should have 1,350 to 1,500 ppm for the adult population. Apply fluoride varnish whenever necessary. Give fluoridated mouthwash whenever necessary. So, just for the last 5 minutes of my presentation, I would also like to share how did we do in our curriculum and how did we train the entire Malaysian region for that matter, and overseas as well. So we started implementing this in 2012, 2013, I would say. And we actually did implementation of this particular ICDAS and ICCMS in 2014. And we published this paper only on implementation. How did we actually implement the entire system of new cardiology curriculum in our day-to-day practice? So definitely we had to have the task force. We had to prepare certain materials for the training. So we prepared all these materials, what you see in front of your screen, where we had to prepare your extracted teeth to train people. We had to ensure that everything has been taken into consideration step by step. We had international experts. So you can see both very I would say bright people in cardiology, Professor Tim Strand and Professor David Ricketts. These two people actually, as I mentioned, I was very fortunate to get my training under them regarding this cardiology. And then we set up the entire thing from top to bottom. How do we need to do this? Like e-learning videos, overview of ICDAS, photographic sessions, assessment. We had prepared a lot of material, and then we carried out 3 projects in which, and we actually presented these projects in different IADR forums. So the first thing what we wanted to present, which we presented a long time back, that which part is better, whether the extracted teeth are better to train or images. And I'm just giving you a glimpse of my projects, just a conclusive part that we found out that when you are having an integration, because as a general dentist, you are performing everything, not only cardiology part, you are performing endo part, you are performing perio part, you are performing oral surgery part. Actually, every one of us can do this because this is our basic bread and butter. And then we realized that extracted teeth are better than the photographic images when you are training people, especially for newcomers in ICDAS. We also wanted to see whether they are able to actually reproduce the results when they do clinical examination, when they diagnose dental caries based on the ICDAS and ICCMS system. And then we presented this one as well. And actually we found that yes, the dental faculty from different specialization, they could diagnose it very well, but they were finding it very challenging, especially in coding code 1 and code 2. And that is why we merged those codes for the better identification. And the third part, what we wanted to see if the radiographic examination, whether they are able to identify and reproduce the results by looking into the radiographs. And there we found very interesting results. The restorative dentists, though they could do a quite decent identification, but I would say the training of radiographic examination was needed. And that gave me an idea that because what is happening now, whenever we look at the radiograph, we just look at this like for a few seconds and we say there is a problem and you do it. So the assessing the radiograph is an art, and that is why I got my oral radiologist here who actually trained people how to read the radiograph very well. And that was very helpful for us to identify dental caries at a very early stages. So with this, this is something I wanted to add on, which is our research, which we are working on now. And why did I add this part? Because I know my next presenter, Dr. Ramya, is presenting on the salivary diagnostic strategies in caries, the role of saliva in caries diagnosis. And we are also working on saliva, but I am working on something else called ginger. So ginger is a natural product. We all use ginger, especially in Indian cuisine. We all use ginger day in and day out. And we are trying to see the effect of ginger extracts. So we have done 3 different kinds of ginger extracts here. And what we have done is this is Chedrol. What you see is the one of the contents of ginger. It has got many contents like Chedrols or gingerols and many more, which you can find out through HPLC. So we found out that when we did it in the mice, it's an animal study where we could see the effect of ginger, and there is an increase in the salivation of when you use ginger, and you see the results. Actually, I mean, this has already been accepted, and soon you will see this paper coming out where we could see the control where there is no ginger given. You can see the saliva increase. There is no increase in the saliva, but there is an increase in the saliva of different types of extracts. And we found the DMSO extract, when we did, it had the best salivation in the mice after certain weeks of treatment. So ginger, those who are not eating ginger, please start eating ginger. So with this, I would like to conclude my lecture that as a dentist, I think if you really want to manage dental caries, you need to broaden your horizon. You cannot just treat dental caries as a dentist. You have to treat dental caries as a dietitian. You have to treat dental caries as a pharmacist, as an educator, and we have to continue doing research as a researcher to understand dental caries better and to apply those management strategies in a holistic manner, so that, as you mentioned, we can make our dental caries not an enemy, as a friend. So thank you once again. Thank you, Mahalakshmi ma'am, for having me. And I'm open to the question and answer session. Thank you.
Thank you, Dr. Abhishek, for a very detailed insight on the holistic caries management of caries. And I totally agree with you that gone are the days of drill and fill. But now the focus should be directed towards elimination of the disease rather than just the lesion. You have to treat the patient as a whole. And for that, we need to know about the causes, to assess the risk factor, to address not just the current lesion, but we also have to focus on preventing the future lesions. So I feel this particular philosophy is sustainable. And if we are able to control all the risk factors and we decide a treatment plan according to the latest methods of detection, that, as you have told, not to use the sharp probe, use the blunt probe, and then we have to treat it in a medical manner, not like in a surgical manner. Thank you so much, Dr. Abhishek, for this. And now we'll start with the question answer. First, one question, my personal question, because the last research you were talking about that related to ginger, it was sounded very interesting. I just wanted to know that how long that increased salivary flow lasted after intake of the ginger.
Yes. Okay. So what we had done in mice. So it's an animal study where we had taken 15 weeks old mice, and we continued doing it for 18 until 19th week. So we could see when, but we had given 3 injections at regular intervals. So we had given injections only 3 injections in 1 week time. So for example, after 15th week, we gave until 16th, and we carried out the experiment. We gathered the saliva after 17th and 18th and 19th, and actually we could see up to 3 weeks there was an increase in the salivation. So that's how we could see after our work what we had done.
Okay, thank you. So now there are some questions from the audience. How do we detect and distinguish between code 1 and code 2 when it's associated with restoration?
Yeah, it's a very interesting question. When there is a restoration, for example, and if you see there is a code 1 and code 2, if you're confused between code 1 and code 2, you're not sure whether it is code 1 and code 2, I will go for the lower score.
Okay.
Code 1. But again, I am not deciding my treatment at that particular moment. That is okay. I understand there is a caries. I understand there is a caries which is associated with the restoration. I'm fine with that. That is one information I have gathered. I still need to gather a lot more information from the patient by asking the history, by looking into the patient's oral cavity, by doing the risk assessment, by using the risk assessment tool, and then only I will decide whether what treatment strategy shall I do.
Yeah, Abhishek, that was a very inclusive and informative session. So continuing with the questions. I have a question here. What is the recommended classification for rampant caries cases?
All right. So again, the rampant rate caries cases in this particular case, we will just consider. Okay. Now the thing is the classification of caries. We are not looking into the classification. What we should look into. We are okay. For example, patient comes to me with a rampant caries, right? Now the rampant caries means patient belongs to high caries risk group. I am not going to treat that patient if having rampant caries. I am going to treat okay. Patient is having rampant caries because of what? So I need to focus on those factors. I will do the caries control measures. I will temporize all my caries lesions, but that is going to be my last stage of doing. But before doing, I have to determine if the patient is having rampant caries, what is the reason behind this? So as Dr. Mahalakshmi ma'am started with, I could not understand that Sanskrit or Tamil words, but the outcome was we have to look into the etiology before we treat. So similarly in caries, we have to really look into the etiology, what is going on in the patient. And that can happen only when we determine and detect and decide, and then we do.
Yeah. Abhishek, can you stop sharing your screen, please?
Oh, yes, I can.
Sonali, you can go ahead. Thank you.
Yes. Another question, why do we need to use a blunt end probe for code 3 and code 4?
Okay, I mentioned this, that you don't need to use the probe at all, but at times what happens is when we look at the Caries lesion, we realize it is code 3, for example, but I'm not sure how deep it is because the cavitation may be a very tiny one, but it may have a frank cavitation underneath. So just to assess that, what will I do? I will put my probe in and gauge the depth of the lesion. So if the lesion is deep, and I realize that it is not 1 millimeter or 0.5 millimeter, it has gone 4 or 5 millimeter, that means it is into dentine. So instead of coding code 3, I will code code 5.
Okay.
Yeah. Or 4, depending on the hue or whatever you have.
The next question to you is, caries on labial surface of anterior tooth involving middle third comes under which class of GB Black's classification? Maybe
I'm asking you. I mean,
yes.
I'm asking you not to use GB Black classification
Maybe
because it's a cavity.
I started with it. Yes. Yeah, it's a different perspective as well, altogether. The next question is, how do we differentiate between a stain and caries in early caries lesion?
Okay, this is a very, very nice question. And I tell you, whenever I have gone for training, everyone has asked me this question, everyone. Okay. And I have given this answer, which you may not agree with my answer. Okay, so you can tell me if you've got a better answer for that. And my teachers are here, so they can help me as well. Now, normally what happens is whatever I have come across in the staining part, you will have staining on multiple teeth. While in caries part, you will not have staining on multiple teeth. That is one of them. I mean, that is one of the major things I would say. Now, staining part, you will have a patient history of, for example, having coffee, tea, tobacco, or sometimes patient may say, for example, if it is enamel hypoplasia or tetracycline staining, that can be quite obvious when you can see in multiple teeth. But when it is really into localized tooth, and you are not very sure about this, then definitely it becomes a challenge for a clinician to identify a caries and a discoloration due to any other reason, for example, hypoplasia or a fluorosis or anything else. So overall, if you are having staining due to any of these habits, definitely you will have in multiple teeth. So I'm not sure whether you're happy with my answer, but if you've got a better answer, please enlighten me as well. I'll be very happy to hear that answer.
another question from the audience, which is the most accurate method for detecting early caries caused by orthodontic treatment? And how do we score when the braces are still there?
Yes. So when the braces are still there, your diagnosis is going to be difficult because your visibility has been hampered. Now, in that case, what do we normally do? See, again, all the question what I've been hearing, it is all about classification. How do you classify? This is very theoretical, this is the problem of our old system. Sorry, I'm saying this because I've been the part of that old system, but that's how we were. Like, this is a classification. I am telling you to break the ice. You just come out of that we don't need to classify the classification of we don't need to know the classification of caries. Now, if there is a caries adjacent to the orthodontic bracket, I will still follow the ICMS. I will still follow, okay, the caries is, can I see under the saliva or not? If I can see under the saliva, I will say code 2, whether there is a cavitation or not. If I see initial enamel cavitation, I will say code 3. If I'm not very sure with my visual examination, I may use the probe. I may use, because at times with the bracket and the wire and all, it may be difficult for me to examine it only by visual examination. So in that case, I may use the probe, but I will use the blunt end probe. So, especially that is why you see all orthodontists, not all, but most of them, when they assess the patient and they realize that patient is not able to maintain the oral hygiene well and plant retentive areas are more, they will give the fluoridated mouthwash to use. And that is the reason, basically what they are trying to do, they are trying to prevent developing new carious lesion. Yeah.
May I interrupt? I think there are still a lot more questions, but
you can email me.
Running short.
Okay.
We are rating into Ramya's lecture, so
thank you.
Yes,
I
yes.
request everyone, we'll send a whole list of questions to you can answer it later.
All right.
Thank
Thank you, ma'am. Thank you so much. Thank you.
Thank
Bye, ma'am.
Thank you. Thank you, Abhishek.
ma'am. Thank you.
Thank you, ma'am.
Kavita, you need to unmute yourself.
Oh, sorry, sorry. So as a token of appreciation, we would like to honor our speaker with a certificate. And thank you, our moderators. You've done an excellent job. We would like to appreciate you with our certificate. Thank you so much.